Hello, everybody. I'm Professor Janvi Tandon and will be speaking to you on healthcare delivery system. But today we are going to discuss healthcare financing. The development team has been guided by Professor Vidya-mitra and his colleagues from Aligarh. Learning objectives. Before every lecture, we must have the learning objectives tightened because upon the completion of this module, we should be able to enlist the important features of public healthcare financing in India, system in India. We should be able to enumerate the core indicators of healthcare financing. We should be able to describe the mechanism of healthcare financing and also enlist the various sources from where the healthcare financing would come. In the introduction, it is important to note that access to healthcare is critical to improving health status and good health is necessary for empowerment. Limited access to public health facilities forces people to go to private providers, a very important point, resulting in substantial out-of-pocket spending, especially for the poor. Making healthcare affordable and accessible for all its citizens is one of the key focus areas of the country today. That is why we keep talking of healthcare becoming affordable, accessible, and it should be easily available. And the healthcare delivery segment is dominated today by the private sector in India, with 70% of the total delivery market catered to by the private sector and the government share being merely 1% of the gross domestic product. In health financing, a health system is a sum total of all the organizations, the institutions, and the resources whose primary purpose is to improve health and services that are responsive and financially fair while treating people decently. Health financing also refers to the function of a health system concerned with the mobilization, accumulation, and allocation of money to cover the health needs of the people individually and collectively in the health system. The purpose of health financing is to make funding available as well as to set the right financial incentives to providers to ensure that all individuals have access to effective public health and personal health care. This is as defined by WHO in 2000. Now, the public health system in India is very important because it has got some three important features. One is the low level of public spending. Actually, when we come to think of it, and from small instance, a person would not like to spend on health, but would like to in fact invest on a car or invest on movement or invest on a house or invest in some other technological know-how. But on health, he would be hesitant. Therefore, in the years 96 and 97 saw less than 1% of the GDP being spent on health by the government, and whereas it was slightly raised on the adoption of the National Rural Health Mission in 2005-06, we saw an improvement to 1.2. A resulting poor quality of preventive care and poor health status of the population and the inadequate level of public health provision has thus forced the population to seek private health providers, resulting in high out-of-the-pocket spending. Out-of-the-pocket spending in India is nearly 4 times higher than the public spending on health care. In order to see if the health financing is good and if the health status is being maintained and universal health care is being given, we have certain indicators by which we can measure the health status of our country. For example, health status of India, we can see infant mortality rate, that is per 1,000 live births, children below 0, below 1, dying per 1,000 live births is by 2012 it was 42. Under 5, and this has definitely been there's been a decrease over the last 20 years, wherein it used to be 80-85 in the early 1900s. And under 5 mortality rate, that is per 1,000 live births, it is 52. Proportion of 1-year-old children immunized against measles come to 74.1. This was in 2009. Maternal mortality ratio has seen a very big drop, and it has come to 178 per 100,000 live births. Proportion of births attended by skilled health personnel, which is very important, which is a good indicator that the services are reaching the the parameters. There is 52. Now, core indicators of healthcare financing by WHO 2008 recommended that total health expenditure (THE) per capita in international and US dollars. The numerator would be the sum of all the health expenditures, ideally from the national health accounts and including all sources of funds, that is external government and non-government, including household out-of-pockets, and the denominator would be the total population. That would give you per person the expenditure per capita. Recommended core indicator is the general government health expenditure as a proportion of the total government health expenditure. These rates would actually indicate as to how far our program was succeeding. Recommended core indicator, another one, is the ratio of household out-of-pocket payments for health to total health expenditures. Number of households in each region where direct out-of-pocket payments to providers for health during the past 12 months was more than 40% of their household income net of subsistence, or 10% of their total income. In most developing countries, self-reported total health expenditure is a more reliable indicator of household purchasing power than self-reported income. So this should be normally used, it could be used as a denominator in these settings, because this actually indicates how much money they are able to spend out of a total income on health, which is necessary. And for those people who really don't have any insurance but do have access to health care. Now, in the pattern of central allocation, that is the total versus the health sector, this is the crores in Indian rupees. From the 8th plan to the 11th plan, we have been seeing a consistent increase. Whether it is total planned investment or health allocation or family welfare allocation or in the Ayush allocation. Ayush means all the traditional forms of medicine, that is Ayurveda, Unani, Siddhi and homeopathy. And total for the health sector has improved from 3.2% to a total of 6.49%. The investment in healthcare to continue. The total spending on healthcare in 2011 in the country is about 4.1% of the gross domestic product. Global evidence on health spending shows that unless a country spends at least 5 to 6% of its GDP on health, and a major part of it is from the government expenditure, basic healthcare needs are seldom met. So the government spending on healthcare in India is now only about 1.04% as compared to what it should be, that it should be more than 5, which is about 4% of the total government expenditure. Perhaps the single most important policy pronouncement of the National Health Policy 2002, articulated in the 10th, 11th and 12th 5-year plans and the National Rural Health Mission framework, was the decision to increase public health expenditure from 2 to 3% of the GDP, still not averaging to what is actually required. In the various countries, now this is a chart which shows actually the amount, the comparison between the total health expenditure per capita in US dollars from around about 2011, and it covers the developing countries like India, Thailand, Sri Lanka, who are spending about, and in fact you can see from the thing that India is spending the least per capita. It is spending only $62 per capita, whereas as compared to even Sri Lanka, which is spending $93, to the BRIC countries which are spending more than $1,000, and to finally the developed countries like USA, UK, Germany, France, where the amount totals to nearly $8,000. USA is in fact spending the maximum $8,467 per capita on health. And therefore, when you compare it to the government health expenditure, you see the same thing, that it is to the tune of nearly 80, anything between ranging between 30% India and to 85% in Norway. And therefore, the life expectancy at birth also will reflect what you have put in terms of healthcare and their needs. So India is at a 66, whereas the rest of and the only other country which is below India is South Africa, but all the rest of them, their ages are in the 80s. Now, mechanisms of health financing. If you want to finance, what is the best method to do it? So there could be either the general revenue or the earmarked taxes which are collected. A portion could be earmarked for health financing. There could be social insurance contributions. There could be private insurance premiums, community financing, and the direct out-of-pocket payments. Then there could be general revenue or earmarked taxes. The most traditional way of financing healthcare is earmarking from the taxes and finance a major portion of the healthcare, especially in the low-income countries. Now, there is also what is known as social insurance. Social insurance, it is compulsory. Everyone in the eligible group where there is social insurance, it becomes compulsory. Everyone in the eligible group must enroll and pay a specific premium contribution in exchange for a set of benefits. Social insurance premiums and benefits are described in social compacts established through legislation, and premiums or benefits can be altered only through a formal political process. Private insurance. Where there is private insurance, private contract offered by an insurer to exchange a set of benefits for a payment of a specified premium. Marketed either by non-profit or profit insurance companies, consumers voluntarily choose to purchase an insurance package that best matches their preference, and it is either offered on an individual or group basis. Under individual insurance, the premium is based on that individual's risk characteristics. For example, they see the weight, they see the blood pressure, and they see the height of the individual and his earning capacity. Major concern in private insurance is the buyer's adverse selection. Under group insurance, the premium is calculated on a group risk. Risk is pooled across age, gender, and health status. And then you have now in private insurance, you have some of these systems which are working all over the world in different parts. For example, now private insurance companies have come in and they give you different packages of benefits for a certain amount, and which would fit the buyer. So once he comes into this group, the insurance people, they under contract, they take in a hospital or private medical people, wherein their people could go at times of difficulty or in ill health. They could show, they be treated, and the insurance people would be able to cover it up. Community-based funding. This is based on the three principles. There should be community cooperation, local self-reliance, and prepayment. Now, factors for success of community financing. Most important is the technical strength and institutional capacity of the local group. Financial control as part of a broader strategy in local management and control of healthcare services. Then support received from outside organizations and individuals, links with other organizations, diversity of funding, responding to other, that is, the non-health development needs of the community, and ability to adapt to a changing environment. That is, if community financing is done, these things must come into being, because they would help in giving 100% coverage to the people coming under their group. Direct out of the pocket would be made by patients to private providers at the time a service is rendered. This is just like you fall ill, you don't have an insurance, you go to a doctor and you pay his fees. But the question, in this case, it is not help because the entire money is coming out from your pocket and is a part of the total income of the family is being diverted towards healthcare. User fees refers to the fees the patients have to pay to public hospitals, clinics, and the health posts, and not to private sector providers. Proponents of user fees believe that the fee can increase revenue to improve quality of public health services and expand coverage. Major objections raised against user fees have been on equity grounds. Now, most important amongst the sources of health financing, that is the private sources, is debt financing from banks and financial institutions. And this is the preferred route. That is, when people want to start the insurance companies, they may want to take loans, or they may want to keep something with the bank, mortgage something, and as such, because the company remains their own and they have to pay back to the bank because loan financing. So this is the debt financing from banks and financial institutions is actually the preferred route for raising capital for smaller healthcare providers, albeit occasionally for large private players as well. Banks at present do not focus on funding healthcare projects in Tier 2 and Tier 3 Indian cities, which are actually the lower level where health is not very complete, and neither are they very accomplished in providing the proper health care. But the growing presence of corporate players in these areas will also encourage the lending institutions. But at present, they are referring only to the Tier 1 and to the Tier 2. Where the high technological players are coming in. Risk evaluation for healthcare projects seems to be the major concern for most banks making forays into healthcare delivery funding in these regions. The current environment is favorable for investments in healthcare delivery projects. The past experience in healthcare delivery has been good with negligible defaults. Banks have research teams for the healthcare but no specific domain expertise in healthcare delivery. They mainly rely on public domain information and specific reports. Banks are actually actively thinking of developing portfolios in healthcare deliveries. Now, foreign direct investments are another thing which is now playing a very huge role in bringing high technology to our countries or to different type of, especially to India. The foreign players are now seeking to enter the Indian healthcare delivery market through various channels, including capital investment, technology tie-up, and some form of collaborative ventures with Indian counterparts in the area of medical technology, diagnostics, healthcare education, and training. The role of foreign financing in the various formats of healthcare is primarily governed by the FDI policy, which permits 100% of foreign investments under automatic route requiring no prior government or RBI approval. Some of the issues that inhibit FDI are listed below. That is the lack of quality assets and the lack of size. Then there could be lack of adequate transparencies where the papers are not very clear, and especially where in the hospitals where they are going to invest, there is no public listing of most of the hospitals. A word before we go into external commercial borrowings is that as far as the foreign direct investment is concerned, let me give you quite a few examples there are today in today's the Indian technological picture. For example, foreign companies are now Apollo Group of medical hospitals have now been collaborated with foreign group in order to increase the number of hospitals, increase the number of beds, increase technology, and give better services. Now, most of Dubai's high classified people are now coming and pouring into money into Kerala, which is now going to become a high technological medical hub in the near future, and also in Andhra Pradesh. Then besides, there are several other people who have been coming in, and big hospitals, especially the Narayana Group in Bangalore, and the Hriday Narayana Group, and several hospitals in the south, mostly based in the south, that is Chennai, Bangalore, Kerala, Andhra. And of course centers like Delhi. Some of the issues that inhibit, because before we go in, because healthcare per se is definitely cheaper, and operations in India would cost 10% of what it would cost outside. So now most of the high technological operations are now being carried out very comfortably in India, and now we are getting a good trade of foreign visitors, foreign medical visitors for medical care. Now, in external commercial borrowings, due to a complexity in the process of getting approvals from the Reserve Bank of India, the healthcare sector has not witnessed many ECBs, because there is some freedom as far as this input is concerned. Further, the government has also decided to permit entities in the hotels, hospitals, and software sectors to avail ECB up to 100 million USD per financial year under the automatic route for foreign currency or rupee capital expenditure for permissible end use. One of the main reasons for popularity of ECBs is the lower interest rates in the US and European markets compared to India. Some of the benefits of ECBs over other resources of funds are: cost of raising ECB is much lower than the domestic borrowing. Global financial market is a much bigger source of credit, and foreign lenders particularly provide far more flexibility in terms of providing security for ECBs, thereby and therefore the influx of foreign money into our country. Now, private equity funds are also investing in companies, and they have a proven track record of profitability and sustainable growth. The fund actually brings in not only the capital but also the adequate strategic planning and management skills set for growth. Most private equity funds are keen on investing in the healthcare sector, given the high growth and the recession-proof nature of the industry. However, this is where the crux is. The soaring real estate costs, issues relating to scalability, management bandwidth, workforce, lack of entrepreneurship, etc., are the major deterrents. Currently, the Indian healthcare market, and particularly on the provider side, offers the following opportunities to private equity funds. That is, actually, there is a high need gap, so they are able to come in. Then there is a limited presence of network hospital system, and there is definitely a skewed bed population ratio, so people are trying to put in more beds for the as the demand is rising. Mostly privatized healthcare delivery, leading to higher spend in the private sector, recession-proof sectors, viable formats, mix of brownfield and greenfield projects, good operating margins, good rate of return as compared to other industries. Existing challenges are actually the real cost estate, the scalability, the clinical and nursing paramedical force which needs to be there, and the lack of entrepreneurship on the people. Now, individual investors have also set up nursing homes or medical centers or diagnostic facilities. These are mainly family-owned business establishments as an entrepreneurial activity. Foreign institutional investors are investment funds registered in a country outside India and include hedge funds, insurance companies, pension funds, mutual funds. They must register with SEBI to participate in the Indian market and are subject to regulatory compliance that places limits on the FFI ownership in Indian companies. And the venture capital fund, these are companies that specialize in financing new ventures, like bringing a new product to the market when the venture may need to attract financial funding. So there are several categories of financing avenues. While smaller ventures sometimes rely on family funding, loans from friends, personal bank loans, more ambitious projects that need more financial funding may turn to private investors who use their own capital to finance a venture's need. Now, the National Rural Health Mission by the Government of India intends to provide healthcare services to the rural population of the country with a special focus on 18 states. It actually reflects the government's commitment to raise public spending on healthcare from from 0.9 to 2 to 3% of the GDP. And it also sets up a task group to focus on the new health financing mechanism. Payment of hospitals for services as reimbursement by district health missions, standardization of OPDs in patients, monitoring of standards by a national health group, and payment of wage component for all existing community health centers on a monthly basis and reimbursement of other recurring costs. Public sources annual government budget for the rural health. The National Rural Health actually was conceived as an umbrella program covering the existing programs of the Department of Health and Family Welfare Department of the central government. The budget head for this was created at the central and state levels with the vertical health and family welfare programs retaining their sub-budget head under the National Rural Health Mission. The outlay of this in 2005-2006 was around 6,700 crores, and the NRHM anticipated an additional 30% over the existing annual budgetary outlays every year to fulfill the requirements. The total urban population in the country as per census is now more than 377 million, constituting 31.16 of the total population. About 15% of the urban population and 23% of the population living in urban slums, with a special focus on urban poor living listed and unlisted slums, because this is important, and thereby the National Urban Health Mission was launched in 2010-11 to 16-17. Poor environmental conditions, high population density make slum dwellers vulnerable to lung diseases now in these close crowded communities with practically very bad environmental conditions. Diseases like asthma, tuberculosis, along with the vector-borne diseases with twice as many cases of malaria and dengue amongst the urban poor are likely to be seen amongst these particular group. And the scheme would actually cover all the state capitals and 430 identified cities with a population of more than 1 lakh. The National Urban Health Mission was aimed at strengthening the primary public health systems, filling in the gaps in the service delivery through private partnerships using a regulatory framework, and also as a community-based risk pooling insurance mechanism. The financial sharing ratio of NUHM between central government and state will be 85-15 during 11th 5-year, and it will come to 75-25 during the 12th 5-year plan with a 25% state contribution. That means this the National Urban Health the mission is gaining importance and will be done well. Government funding for community programs. We have had a lot of community programs, some of which we have been able to control, some of which are still going on, and investments, and we have to make them sustainable by developing robust systems and supporting the local capacity. So in these cases, in vector-borne disease control, reproductive child health, we have to reduce the infant child mortality by improving quality, coverage, and effectiveness and of the existing family welfare programs. And the National Tuberculosis Control Program, the goal of this is to see that to cut down, decrease mortality and morbidity due to tuberculosis and cut the transmission of infection. This program aims to achieve and maintain a cure rate of 85%. And now the Blindness Control Program. This program was launched as a 100% centrally sponsored scheme to reduce the prevalence of blindness from 1.4 to actually 0.3%. And the program was to develop eye care facilities in every district, securing participation of voluntary organizations in eye care and developing human resources for providing eye care programs. And similarly, other programs like leprosy eradication program, iodine deficiency disorders control, all of which have a heavy influx on the health aspect. So they have all to be controlled, and in such a way that these programs continue for a long time and bring down both the mortality and the morbidity. And of course, the government has been giving certain incentives For example, in the family planning program, incentives were given to the woman who was coming for family planning, to the person who was finding this case, and to the person who was actually inserting the IUCD or doing the operations. Then in government sponsored insurance schemes are there. Less than 10% of India's population today has any form of health insurance. We don't have health insurance coverage, but most of the others are part of the ESI, is of course there in the cities and central government health service programs. And this is particularly in places like Delhi, etc. So, tier 3 cities and rural areas are marked by a negligible insurance coverage. But the government has been able to launch certain important programs like Rashtriya Swasthya Bima Yojana, and which provided access to quality health care to the vast population living below the poverty line. And in this, there was also a scheme of 30,000 rupees would be reimbursed annually for medical treatment. Incentives and subsidies uh, were permitted under the automatic route, and of course, now these schemes are either provider based models or insurers models or linked models. And some good examples of the government schemes which have been now operating in the rural areas and providing protection against health expenditure are the Rajiv Arogya Shri in Andhra Pradesh, Arogya Raksha Yojana, Yashaswani Cooperative Farmers Healthcare System, Karuna Trust in Karnataka, Jeevan Day Arogya Yojana in Maharashtra, Bimo Seva in Gujarat, and some international donor organizations are very active in India still. For example, the Bill and the Melinda Gates Foundation, Clinton Foundation, then the US Aid. And the reasons for identified for low penetration of health insurance, in particularly the lower levels, are definitely listed below, and they are because of the low awareness and inability to comprehend the benefits of health insurance. Besides that, because of the lack of education and the lack of understanding, the lack of communication, and the lack of health education, they are not able to comprehend the benefits of health insurance coverage. Then there is unavailability of schemes addressing individualized needs. Then there is no mechanism available to the beneficiaries allowing for a systematic appraisal of the quality of services provided. Then there is a lack of insurer efforts to promote health insurance and negligible number of providers in the rural areas for availing the benefits of. And other sources are, of course, foreign donations are coming in, and the PPP project fundings are there. Most typical sources of funding 16 available for PPP are listed as financing from central or state government, complete cover of capital expenditure inclusive of land, the viability gap, financing from external agencies, private partners, annuity-based financing for healthcare infrastructure. At the end, it is very much evident that huge investments would be required in developing and upgrading of health infrastructure in order to improve accessibility and quality of care. The private sector must consider this as a business opportunity to establish their presence and expand their operations or market share in the healthcare delivery market in India, either by partnering with different state governments or pursuing a pure private model. The government at the same time needs to understand the issues faced by the private sector currently, working either independently or in the existing public private partnership program, and to take measures to improve the investment climate in the respective states. The states will need to put in place clear policies and guidelines in the healthcare sector, which will in turn attract large private investments in the healthcare industry. So, thank you for visiting ePathshala today.